Let's initiate the clinical simulation. We're completely bypassing the standard intros today and jumping straight into the parameters for high-yield, catastrophic third trimester emergencies. This explainer is strictly designed for top-tier clinical integration, targeting a perfect 270-plus score performance. You need to rapidly assess, diagnose, and execute life-saving interventions in the face of massive obstetric hemorrhage. Right off the bat, here is your high-yield directive. To absolutely master these catastrophic scenarios, you've got to be able to differentiate the precise hemodynamic signatures of vascular versus mechanical disruptions in the pregnant patient. We're looking at absolute management protocols here, where even a second of hesitation results in maternal and fetal mortality.
Let's kick off with Module 1, placental abruption. The mechanism we're dealing with here is vascular shearing. We're talking about the premature separation of a normally implanted placenta from the uterine wall right before delivery. You must recognize the specific drivers of this violent separation. It is strictly driven by factors like maternal hypertension, cocaine use, or severe abdominal trauma.
Now, to spot this instantly on the wards or in a vignette, you need to lock in the clinical triad. It presents explosively with sudden onset, painful, dark vaginal bleeding, a rigid and exquisitely tender uterus, and high-frequency, low-amplitude, or hypertonic contractions. The uterus is essentially in a state of tetany, desperately attempting to clamp down on that bleeding vascular bed.
But here is the hidden danger, the hemorrhagic trap. When that placenta violently shears off, it doesn't just bleed. It literally dumps massive amounts of tissue factor, or thromboplastin, directly into the maternal systemic circulation. And that is a potent procoagulant.
That tissue factor? It triggers disseminated intravascular coagulation, or DIC. This consumptive coagulopathy operates with terrifying kinetics. First off, you get this catastrophic depletion of fibrinogen and platelets. Next, on your laboratory workup, you'll see elevated PT and APTT as the clotting cascade is aggressively activated and then completely exhausted. Third, you'll find an elevated D-dimer due to the presence of fibrin split products. And finally, the sheer force of red blood cells moving through these microthrombi will cause microangiopathic hemolytic anemia.
All right, we need to establish a strict clinical boundary right now. Painful bleeding with a rigid, tender uterus, that is placental abruption. But painless, bright red bleeding with a soft uterus, that's placenta previa. And if you even suspect previa based on that lack of pain, there is an absolute, strict contraindication to any digital cervical examination. Don't do it. Doing so could blindly puncture the placenta right over the internal os, causing an immediate, fatal hemorrhage. Let's put this into practice with an integrated assessment. You've got a hypertensive patient at 36 weeks gestation, presenting with a rigid, exquisitely tender abdomen and dark red vaginal bleeding. So what is the absolute most critical next step in management? You have to prioritize systemic stabilization over an isolated local evaluation. Let's look at the options.
Let's break these down exhaustively. Choice A, an immediate digital cervical exam, is a massive lethal trap. It is absolutely contraindicated with third trimester bleeding of unknown etiology until you rule out previa via ultrasound. Choice B, giving terbutaline, is completely incorrect. Tocolytics are strictly contraindicated in a severe abruption when your patient is hemodynamically unstable. Choice C, evaluating a coagulation panel, is exactly the correct answer. You are mandated to do an immediate assessment for DIC to intercept that systemic release of tissue factor. Choice D, an isolated transvaginal ultrasound, is a classic trap. Sure, it's highly sensitive for previa, but in a severe abruption, clinical stabilization and checking for consumptive coagulopathy take absolute precedence. And finally, choice E, reassurance and discharge, is a fatal error. This patient is at imminent risk of hemorrhagic shock.
Moving right into Module 2, let's see how this builds our understanding of mechanical failure. We're shifting from vascular shearing to structural disruption, uterine rupture. This is the catastrophic tearing of the uterine wall, and it overwhelmingly happens at the site of a prior cesarean delivery scar, specifically when a patient is undergoing a trial of labor after cesarean, or VBAC.
The hemodynamic signature and physical exam findings here are completely pathognomonic. The patient is going to experience sudden, excruciating lower abdominal pain. Right after that, you'll see a complete cessation of uterine contractions on the tocodynamometer. But crucially, the definitive fetal marker is the sudden loss of fetal station. The fetus literally retracts upward into the maternal abdomen, and you can actually palpate fetal parts directly through the maternal abdominal wall.
The exact second you clinically identify these pathognomic markers, your absolute management directive is triggered. Immediate, emergency laparotomy. There is zero room for delay here.
So the crucial skill here is distinguishing between these two catastrophic events. Let's contrast abruption versus rupture. Yes, they both present with severe pain and fetal distress, but abruption gives you hypertonic, high-frequency contractions and a rigid uterus. Uterine rupture, on the other hand, features a sudden, complete cessation of contractions, that sudden loss of fetal station, and those palpable fetal parts in the abdomen.
Time for your second integrated assessment. A patient at 39 weeks undergoing a VBAC develops sudden, severe tearing pain, profound fetal bradycardia, and the presenting part is no longer palpable on vaginal exam. What's the most appropriate next step? You need to recognize the mechanical failure here and execute the exact surgical protocol. Let's evaluate the interventions. Let's dismantle these options. Choice A, oxytocin augmentation, is a lethal trap. It's going to violently exacerbate the tear that's already there. Choice B, a forceps gestation vaginal delivery, is incorrect and frankly physically impossible because of that sudden loss of fetal station. Choice C, immediate emergency laparotomy, is absolutely correct. It's mandated to instantly control the maternal hemorrhage and rescue the extruded fetus from the peritoneal cavity. Choice D, epidural anesthesia administration, is a trap that's just going to mask the catastrophic hemodynamic collapse happening in front of you. And choice E, expectant observation, is a lethal trap that rapidly leads to maternal and fetal mortality.
All right, entering Module 3, we are shifting to vasa previa. This is an aberrant vascular anomaly you'll see with a velamentous umbilical cord insertion or a bilobe placenta. Basically, fetal blood vessels run entirely unprotected through the amniotic membranes, crossing directly over the internal cervical os.
The rupture kinetics we're dealing with here are explosive. The presentation is instantaneous. The precise moment those membranes rupture, whether that's artificial or spontaneous, it presents with painless vaginal bleeding. But here is the absolutely critical distinction. This blood is strictly fetal, not maternal. And because total fetal volume is so incredibly minuscule, this leads to rapid fetal exsanguination. You'll see it marked by profound fetal bradycardia and sinusoidal heart rate tracings.
This visual data brilliantly illustrates the distinction in fetal monitoring. Notice the standard variable decelerations. You can observe that abrupt drop from baseline to nadir in under 30 seconds, which is typical of umbilical cord compression. But in vasa previa, you won't see that recovery. Instead, you see catastrophic sustained bradycardia or a sinusoidal pattern that strictly indicates severe fetal anemia and terminal exsanguination.
Let's lock in this clinical variance. Placenta previa causes maternal bleeding. Because of that, the fetal heart tracing initially remains reassuring, and the timing of the bleed is totally unrelated to membrane rupture. Vasa previa, however, causes direct fetal bleeding. That fetal heart tracing is going to collapse into a profound deceleration the precise moment the membranes rupture. All right, here's your final high-stakes integrated assessment. A patient undergoes a routine amniotomy. Seconds later, painless vaginal bleeding is noted, and the fetal heart rate drops instantaneously to 60 beats per minute. What's the diagnosis, and what is the required intervention? Let's deconstruct the matrix.
Deconstructing these choices. Choice A, placenta previa with strict bed rest, is incorrect and fatal. That immediate tracing collapse proves the bleeding is fetal, not maternal, making bed rest a lethal error. Choice B, placental abruption with vaginal delivery, is incorrect. The bleeding here is painless and explicitly tied to the amniotomy. Choice C, uterine rupture, is wrong because we lack the severe tearing pain and sudden loss of fetal station. Choice D, vasa previa requiring emergent cesarean delivery, is absolutely correct. The unprotected fetal vessels were iatrogenically ruptured during the amniotomy, so emergent surgical delivery is your absolute mandate to halt the exsanguination. And choice E, normal labor with expectant management, is a lethal trap. Without intervention, that fetus will completely exsanguinate within minutes.
This brings us to our definitive clinical axiom. In catastrophic obstetric hemorrhage, exact identification of the hemodynamic signature dictates survival. Maternal stabilization always precedes fetal resuscitation. Master these distinctions to secure high-yield clinical precision. Simulation concluded.